I am Mike Shoemaker. I'm a professor of physical therapy at Grand Valley State University in Grand Rapids, Michigan, and a practicing physical therapist at Corewell Health. And on behalf of my colleagues, Crystal Gluch, Katelyn Preston, Ashley Van Dam, and Molly Fagan, I'm excited to share with you this video and talk about the commentary that we wrote regarding the study entitled Diagnosis of Deep Vein Thrombosis in Outpatients with Musculoskeletal Disorders, a survey of orthopedic and sports academies by Manske et al. We were really excited to have the opportunity to review the article and provide a commentary, in part because the issues raised by the article really resonate with us in our clinical experience and the ongoing discussions that we have with each other and as we're continually consulting with each other on patient cases. The challenges that we face in decision making just really resonated with us. It also resonated with Dr. Gluch and I on some of the research we've done previously using clinical vignettes to assess clinical decision making. But what was especially poignant in the article by Manske et al. Was the discussion regarding the probability of an alternative diagnosis as least as likely item in the Wells clinical prediction rule. I'm not sure any of us really paid a lot of attention to that specific item in the Wells clinical prediction rule, probably because of our general disposition towards venothromboembolism. And that general disposition is one of guilty until proven innocent. And this is the motto we essentially live by in our clinical practice, and it's also a rule of thumb that we teach to our students. Some of you may remember some of the discussion that took place early on at Combined Sections meeting when the original guideline development group presented on their progress on the VTE clinical practice guideline. And in that presentation was some discussion about the Homan sign and the idea that we maybe want to ban the Homan sign from our lexicon in physical therapist practice. Because, yeah, of course, calf pain should make you think about DVT, but certainly a negative Homan sign or the absence of that symptomology certainly should not cause you to think that you have ruled out DVT. And indeed, I think many of us have had experiences where DVTs have presented with atypical symptoms, some with minimal symptoms at all, and unfortunately, in some cases, presented later as pulmonary embolism because they had asymptomatic DVT. So that rule of thumb has really guided our practice for many, many years. And in reading the article by Manske et al., I think we were particularly struck by vignette number 3, which was a case of a postoperative patient, arthroscopic surgery, and in whom the alternative diagnosis, at least as likely, was invoked and then significantly changed the overall score and therefore drove the decision that DVT was unlikely and that referral or consultation then would not happen. And this really brought to light for us this idea of the alternative diagnosis, at least as likely, and thinking about how to reconcile that with the mantra, guilty until proven innocent. And as we were having this discussion, one of our third-year DPT students had shared a clinical story that she had just encountered in a very similar patient. This patient was post-arthroscopic repair, had calf pain and tenderness without significant edema, and according to a literal interpretation and use of the Wells clinical prediction rule, would score as unlikely and therefore not trigger a referral or consultation. And the interesting twist to this particular case was that that patient had just been in for a routine follow-up with the surgeon that morning, reported the symptoms, and those symptoms were dismissed as a muscle strain. When those symptoms then were reported to the DPT student grew concerned, was using the mantra of guilty until proven innocent, and decided to send that patient to the emergency department for ultrasonography, which did ultimately reveal that this patient did indeed have a DVT. And so that very timely case, I think, really highlights the crux of the issue that gets addressed here in the Manske et al. Article, and the concerns that do exist regarding the alternative diagnosis, at least as likely criterion in the Wells clinical prediction rule. And certainly there may be cases where an individual maybe was doing calf raises, or they remember doing a particular movement that caused stress or injury to their calf muscle, for example, where you would say that is the likely cause of that patient's symptomology. And there are times where you would appropriately invoke the alternative diagnosis as likely item in your decision making. I think the question becomes, how literal are you in your explicit use of the Wells clinical prediction rule, and particularly that item, and are you aware of potential errors in decision making, things like confirmation bias and other sources of error that might cause you to believe you think it's something alternative when in fact it may not be. So in the end, I think our commentary really is an admonition about the Wells clinical prediction rule, and perhaps the alternative, at least as likely item within that clinical prediction rule, maybe serves more as an admonition to gut check one's decision making and search for potential sources of errors in that decision making, as opposed to a literal item that should be scored without due consideration for potential sources of error. We applaud Manske et al. For their work on this study. We think this is a great check-in on the state of our profession and whether or not we are evolving as we need to with regard to differential diagnosis and medical screening for things like DVT, and whether or not our education is evolving accordingly. And we appreciate the opportunity to have provided a commentary on that paper.